Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm joined today by Dr. Walter Hembree and Dr. Kathryn O'Connor, orthopedic surgeons who specialize in foot and ankle surgery. While foot and ankle disorders are common, they can also be complicated to treat, especially in cases where surgery is necessary. That's why it's important to see an orthopedic specialist experienced in foot and ankle care if you have a complex condition. Today, we'll be focusing on surgical options for some of the most complex conditions and the importance of seeing an orthopedic specialist experienced in foot and ankle care. So if you have questions for our experts, ask them in the comments, give us a like, let us know you're watching, and share this broadcast with your friends and family. Before we get started with the questions, let's meet our experts. Dr. Hembree, can you please introduce yourself and tell us a little bit about your specialty?
Yeah, of course. I'm Walter Hembree, orthopedic surgeon specializing in foot and ankle surgery. Went to undergraduate school at Wake Forest University and then proceeded to Duke University for both medical school and residency. Came up to Baltimore for a year of specialty training in foot and ankle surgery. Was out in private practice for about 5 or 6 years and then came back to Baltimore, where I've been in practice now going on 5 years. And I cover primarily the Baltimore region. So I work out of 5 or 6 locations in and around Baltimore, including MedStar Harbor, MedStar Union Memorial, MedStar Franklin Square, and I also have a clinic out in Frederick.
All right, thank you, Dr. Hembree. Dr. O'Connor, why don't you introduce yourself?
Hi, my name is Kate O'Connor. I went to the University of Connecticut undergraduate. I did medical school at the University of Rochester and residency at Mount Sinai in New York City. I went to St. Louis for a foot and ankle fellowship at Washington University in St. Louis. And then after that, I worked for 5 years at the University of Pennsylvania in Philadelphia. I've been at MedStar for 2 years. Started in January of 2021. I see patients in Olney, Maryland, in Brandywine, Maryland, and also at our new office in Gaithersburg.
All right, thank you so much. Let's get into some questions. Dr. Hembree, let's start with you. What are some of the reasons that surgery is needed for a foot and ankle disorder?
Gosh, that's a
lots of reasons,
question.
Right?
Could be any variety of things, I guess. I mean, certainly there's the acute problems, acute fractures, unstable ankle fractures, unstable foot fractures, certain tendon ruptures like Achilles tendon ruptures. And then there's more kind of the elective realm, I would say, things like bunions that don't respond to conservative treatment, arthritic conditions, be it in the foot or the ankle, and sports injuries as well. So sometimes patients can develop instability syndromes around their ankle and or foot that need surgery.
All right, thank you so much. So lots of different reasons why someone would need surgery. Dr. O'Connor, are some individuals more likely to need surgery for a foot or ankle condition?
Not necessarily. So some patients we know that there's a little bit of a genetic component to bunions, but not every bunion needs surgery. Certainly individuals that are very active or play sports just put themselves at risk for orthopedic injuries such as tendinitis or ankle sprains and ankle instability, fractures and things like that. But I think foot and ankle conditions affect everybody in a different way.
Mm-hmm. Makes sense. Thank you so much. Dr. Hembree, on average, how long does it take to recover after a foot or ankle surgery?
Yeah, I mean, that's really broad. Again, it's a great question, one I receive all the time in the office with my patients. And it really depends on multiple factors. It depends on the condition and the type of surgery, and also depends on patient factors. I would say on average, anywhere from 6 to 12 weeks, but it could be something as simple as a hammer toe, which just takes a couple of weeks sometimes to kind of heal and get back up to snuff, so to speak, versus your more complex traumatic injuries, fracture dislocations around the ankle, distal tibia fractures. I mean, these types of injuries can take upwards of 6 to 12 months to fully recover.
Okay, thank you. So yeah, wide range of recovery times. You both talked about bunions. Dr. O'Connor, what about surgical options for bunions? Is surgery the best option, or are there minimally invasive options for bunion surgery?
So there's multiple answers to this question. So is surgery the best option for bunions? And the answer for that is if everything else hasn't worked. In many ways, bunions can be treated pretty well with shoe wear modifications, making sure people have shoes that are wide enough, and sometimes different inserts and orthotics can help too. So if people are unable to get pain relief for that, then we talk about surgical options. So surgical options, there are in the past 3 to 5 years, people have started to do what we call minimally invasive bunion surgery. That's that's sort of new and upcoming in the field of foot and ankle orthopedics. So that is an option. Not everybody does it. Some people do, some people don't. And then traditional bunion surgeries are also an option as well. And usually the most important thing for bunion surgery is that it's really done for pain management. That the big toe is just uncomfortable and unable to be thing, and that we're making sure we're doing the surgery for the right reasons. And that's the most likely way to get some success out of bunion surgery.
Okay. Thank you very much. Let's talk about arthritis. Dr. Hembree, are there surgical options for treating arthritis in the foot and ankle?
Yeah, of course. I mean, I'll probably comment primarily on ankle arthritis. I think that traditionally the gold standard for ankle arthritis from a surgical standpoint has been ankle fusion. But I will say that ankle arthroplasty or ankle replacement has come into its own really over the last 10 to 15 to 20 years, probably. The second and third generation implants that are on the market nowadays are much better than the implants that were being utilized back in the 70s, 80s, and 90s. And so we're seeing better outcomes, better survivability of the implants, meaning that they last longer. And so that's ankle arthroplasty, I think, is kind of coming to its own as a niche field, as it were, for patients with end-stage ankle arthritis, because it's very good at alleviating pain, but it also promotes motion and retains motion in the ankle joint. And, that being said, not every patient is a candidate for ankle replacement. Some patients do very well with ankle fusion, also. And so it's a conversation with your surgeon in terms of which option is best for you. What are your thoughts on that, Kathryn? I was hoping to get your take as well.
Yeah, I think ankle fusion and ankle replacement is always a very good debate. I think there's a lot of things that need to be considered: patient's age, the amount of deformity, if their ankle is straight versus the ankle is crooked, and sort of what the patient's goals are, and also where they are. If they have a very stiff ankle to start with, it might be worth just doing a fusion to not have to worry about the possibilities of issues with the hardware down the line if they're younger. So I think it's a very interesting field and an interesting topic of discussion for everybody in foot and ankle orthopedics. And we don't totally know the best answer. So it's definitely something shared decision making between the patient and the surgeon, and understanding what the goals are, what we want to do, and to make sure we make the best decision for patients for it.
Thank you. And Dr. O'Connor, what is the difference between ankle fusion and ankle replacement? You've both mentioned both of those.
Yeah. So like Dr. Hembree said, for a long time, we didn't have the technology to do an ankle replacement. And that's where you put in 2 pieces of metal and a piece of plastic in between, much like a hip or a knee replacement, which are much, much more common. Ankle replacement exists, but it's just done on a much smaller scale. I always tell my patients, we do 500,000 knee replacements a year, 500. In foot and ankle, we only do 5,000 ankle replacements a year. So it's 2 magnitudes less common. So it's an emerging technology in many ways. So it puts a bearing surface that allows you to maintain motion in the ankle. Whereas in ankle fusion, we didn't have the technology until really, like you said, the past decade. And ankle fusion just takes the 2 bones and it makes it so that the tibia and the talus, those are the 2 bones that make up the ankle joint. It makes it so that those sort of turn into 1 bone. So you lose the motion at your ankle, but you don't have arthritis there because the joint has basically gone away because we've fused the joint. So the trade-off is that you end up with an ankle that's has much less motion, but it's a surgery that lasts indefinitely. So there are pros and cons to both of it. And many patients that have arthritis have significant stiffness anyway. So that's always a good discussion. Many people get very nervous about, oh, my ankle is not going to move. But many patients with arthritis, their ankle doesn't move a lot in the first place. So it's just different ways to look at it, and the different things you need to consider when you're trying to decide between the two.
Yep. Thank you so much. Let's talk a little bit more about technology. Dr. Hembree, is 3D printing technology used for foot and ankle surgery yet?
Yeah, absolutely. I think kind of to piggyback on our total ankle discussion or our ankle replacement discussion, many companies that make ankle replacement implants are now utilizing 3D technology to custom fabricate those implants, especially for revision scenarios, or make them patient specific for certain deformities. There is an emerging field of 3D printing in foot and ankle space for other scenarios as well. Post-traumatic scenarios where there may be a lot of bone loss and you need a custom implant that will account for the lost bone or that replaces the lost bone. And that's becoming more common. There's also 3D printing for the talus, which is Dr. O'Connor mentioned is one of the bones that makes up the ankle and one of your a number of your hindfoot joints. That bone can sometimes become diseased, painful, and collapsed, especially in traumatic situations or post-traumatic situations. And that bone can be replaced now with a 3D printed construct. And so there's some newer studies out with early follow-up, admittedly, but showing relatively good results in terms of pain relief and function with what's called a total talus replacement, where we get an imaging study of the opposite, the uninjured extremity, and then the technicians will model a talus bone printed either in titanium or metal, cobalt chrome, that matches exactly your normal anatomy, and that can be implanted into your foot and ankle to alleviate pain and maintain function.
Wow, that is incredible. Thank you so much. Let's pause for just a moment. I want to welcome our viewers again to this broadcast. I'm Karen Zingle. I'm joined today by Dr. Walter Hembree and Dr. Kathryn O'Connor, orthopedic surgeons who specialize in foot and ankle surgery. We've talked a lot about surgery options, the needs for surgery. If you haven't done so already, give us a like, let us know you're watching, and share this with your friends. As you've heard from Dr. Hembree and Dr. O'Connor, this could really affect a lot of different people. There's multiple reasons why you could need surgery for a foot and ankle disorder. So I want to make sure we get this information out to everyone that we can. So please share this broadcast. Let's talk a little bit more about the types of common foot and ankle conditions that could require surgery. So we talked earlier about reasons. These could be very similar, but let's go back to that and talk about the most common foot and ankle conditions that require surgery. Dr. O'Connor, can you start and give us some of those?
I think, we've touched on bunions. Certainly, bunions are what we call hallux valgus. That's a very common reason people see us, or hammer toes, toe deformities that can become very painful. That's very common. We've touched on ankle instability and sort of sports related injuries. So people that sort of sprain their ankle and sort of sprain it over and develop ankle instability, that's a very common procedure. Achilles tendonitis as well. And then we've talked a lot about ankle arthritis, but there's actually arthritis that occur all over the foot because there's 20 plus bones in the foot that can all become arthritic in some capacity. So there's multiple different procedures for management of arthritis in all those different spots. So I think all of those can respond very well to surgery.
Okay, thank you. We actually have a related question from Ron. Ron, thank you for your question. He's asking about plantar fasciitis. Is that something we treat with surgery, or are there different options to treat that?
That's a great question. so plantar fasciitis is a very difficult thing to manage. It's almost everybody at some point in their life will have it. I also always tell patients when I see them in clinic, we go to meetings every year, the Foot Society meeting and the Orthopedic Society meeting, and there's always a symposium on plantar fasciitis. And in that symposium, people have tried everything, and no one has anything that's a magic bullet for plantar fasciitis.
Okay.
Frequently, we don't treat it with surgery because the plantar fascia provides some structural support to the foot, so we don't want to operate on it if we don't need to, because it's a soft tissue. And some people say, oh, well, can we release it? But that can change the architecture of your foot and can cause problems other ways. There's a few other surgeries that have been described, but none of them provide really amazing results. So it's something that some people do, some people don't. It's best treated actually with very, very regimented stretching and Achilles strengthening. Those are the best ways to really manage it. And only in extreme circumstances do we really talk about surgical options for it. I don't know, Walter, what's your feeling?
Yeah, Dr. Hembree?
Yeah, no, I would echo all of those comments. It's extremely common. It's very painful. The good news is most of the time it will eventually burn itself out and go away on its own if you can wait it out long enough. Now that can take upwards of a year or more. Though. What's that?
It might be 2 years. I had it personally.
No, yeah, no,
months.
I'm saying it can take years, unfortunately. And as Dr. O'Connor mentioned, I mean, there's a lot of things to try before surgery, be it, casting or booting, orthotics, physical therapy, stretching. There are some less, what I like to call, quote unquote, less mainstream interventions, things like growth factor injection, shockwave therapy. These are interventions that are, arguably less proven in the scientific literature. And for that reason, insurance companies often don't pay for them. So they can be an out-of-pocket expense to the patient, but they are out there and available if you want to seek that out. But I would agree also with Dr. Connor, the mainstay of treatment is going to be stretching. And I would caution against steroid injections. Maybe one steroid shot is a last resort option, but we're really getting away from steroid because it tends to be just a Band-Aid. And you don't want to get in that cycle of injecting over and over and over again, because that can actually cause more problems and issues in that tissue in the bottom of your foot. And then very last resort is surgery. And again, as Kathryn alluded to, I mean, surgery is not a silver bullet either. So sometimes we do it, and unfortunately patients still have some indolent pain in their heel, and then we're just kind of stuck spinning our wheels. So I reserve surgery as a last resort option for that condition, and wait for patients to have pain for at least a year, minimum 6 months to a year before we even start the surgical discussion, because most of the time it'll get better on its own too.
Okay, thank you both. Dr. O'Connor, you mentioned bunions when you were talking about the common, and earlier you had mentioned surgery really to help alleviate pain. We have another question from our viewers. This is from Elena. Is there, even without pain, so she is mentioning bunions without pain, but affecting balance as you age. Is that a reason for surgery for a bunion?
I think in that scenario, I would actually probably say if there's issues with balance, the great toe helps provide some balance, but it's not a main, it has a role in balance, but certainly I wouldn't necessarily expect that it would be the primary source of a balance disorder. So in that situation, I would always try a course of physical therapy to start, just to make sure that there's not other things contributing to feelings of imbalance. That's, again, the decision for surgery for bunion is usually based on pain. Occasionally somebody has a bunion that's so bad they just physically can't get into a shoe, right? And in that situation, you have to get people into shoes, right? We need to wear shoes. But for balance, I would say make sure that all of the other reasons that could be contributing to a balance difficulty are addressed first. Now, certainly a super, super severe bunion could potentially have some effect, but a relatively mild bunion, I wouldn't necessarily expect to.
Okay. Thank you so much. And thanks again for your questions. Keep them coming. We'll ask them during the rest of our discussion. So I have some questions about fractures. Dr. Hembree, fractures being, we talked a lot about active people and playing sports, and you could get injured through that. So fractures being a potential that could happen there. Can fractures be repaired surgically?
Yeah, I mean, absolutely. The short answer is yes. The longer answer is not every fracture needs an operation. And so there's, number of fractures around the foot, for example, like a toe fracture, toe bone fracture called a phalangeal fracture, frequently simple fractures of the metatarsal bones, some of the longer bones in the forefoot. These types of fractures can often be treated with immobilization in a boot and don't need surgery. Fractures that are significantly displaced, involve a joint, or create some degree of instability around your ankle and or hindfoot, those are the ones that often need surgical intervention. And probably the most common of those in terms of what we see is going to be an ankle fracture, extremely common, especially in active individuals, and also very common in the wintertime, especially with the weather. So when it's icy out, patients get out, slip and fall, get in the mail, that type of thing, and will unfortunately sustain ankle fractures, and those often need surgery to restore the alignment, stabilize the ankle, and maximize the function for that patient in the future.
Okay, thank you very much. Dr. O'Connor, I want to talk about foot deformities. I don't think we mentioned that as a reason for surgery. So are there surgical options for treating foot deformities?
Yeah, so foot deformities is actually a relatively common thing we see. Certainly many people have flat feet, but then there's also people that have high arched feet, what we call cavus feet. Both of those, depending on where people are in the spectrum, certainly there's a spectrum to all of this. Depending on and again, I always reiterate, if you have a painless deformity, let's see if we can work to make that fine. Just having a deformity doesn't need to be corrected. It's if you have pain with deformity. That's a very key point of what we do. So patients that have symptomatic deformity, there's a combination of things we do. Sometimes the deformity is so severe, we need to reroute tendons, cut bones, and realign the foot. Sometimes there's arthritis that accompanies a deformity. In those situations, we sometimes have to do fusions to put the bone in the right place and get it to heal in the right place. So there's different surgeries we do to sort of correct the foot, and it just depends a little bit on what we see in each individual foot, whether there's arthritis or no arthritis, where strength is with tendons, where strength isn't with tendons, and things like that.
Okay, thank you very much. I'm going to ask another related question. I mean, it's a different condition, if you will, but what about surgery for an Achilles tendon tear? Dr. Hembree, I'll ask you this one. Is surgery the best option for repairing that?
Yeah, I mean, that's a loaded question. Probably depends on who you ask. I would say in general, in the United States, surgery is more common and preferred. There are certainly other areas of the world, in particular Europe, where non-operative treatment of Achilles tendons is more common, probably for the average person. There are pros and cons to both of those approaches. I will say traditionally, we're always taught that surgery resulted in less chance of re-rupture, but that has not been borne out in more recent studies that employ what's called a functional rehab. And by functional rehab, I mean if you have an Achilles tendon rupture, you could feasibly treat it with early weight bearing and a protected brace like a boot and early physical therapy and have a decent outcome. But a lot of those studies have also shown that ultimate strength and function is a little less in the non-operative patients. And so we still, in general, prefer surgery in the US because, at least in my opinion, I feel like it offers patients better strength and potentially better function down the road, especially for active individuals, younger individuals. I do treat Achilles tendons non-operatively occasionally, depending on patient needs and other medical conditions that may come into play with surgical risk. But yeah, I think in my practice, surgery is generally preferred. What are your thoughts, Kathryn?
Yeah, I'm similar. Certainly there is evidence to support non-operative management, and I probably am about 60-40, 70-30 operative to non-operative. I think the biggest thing is to understand the risks of surgery. And so patients that have risk factors for complications with surgery, since you can get very good results with a non-operative regimen, I think that patients that have uncontrolled diabetes, patients that are smokers, people who know they're inactive, all right, who don't go to the gym and don't work out, maybe they don't necessarily need that little bit of extra power and stuff that you get with a surgical repair. So I always have a discussion sort of about what people do and how we decide to do it. But I think more often than not, we do sort of tend to err on the side of surgery than non-surgery. And in addition, we talked about minimally invasive before. I think some of the technology for Achilles has improved, that we used to have to make a 3, 4, 5-inch incision to do the repair. And now we can do it many times through just about a 1-inch incision. So the risks of complications for wound healing and stuff, which is something that we worry about a lot with that, is actually decreased with some new technology to repair them.
I would like to follow up too. I think if you're considering non-surgical management, it's very important that you get seen right away, at least by an ER urgent care. And it's also important that they put you in a splint or a brace with your foot in what's called plantar flexion, your toes pointed down. And so I know Kathryn sees this all the time too. We'll have a patient come in who's 2 or 3 weeks out from a rupture, who's either been walking around on it in a regular shoe or got splinted in neutral or even dorsiflex position at the foot. And then the tendon's already stretched out and pulled apart. And that makes treating it without surgery much less optimal, and increases the risk of having a poor outcome with non-operative treatment in terms of loss of strength and push-off power. And so again, just critical, they say within 2 days it should be in a plantar flex position in a splint or a cast until you can follow up with an orthopedic surgeon to have a discussion about what the next steps are.
And I think I'm sorry, we could talk about Achilles.
No, go ahead.
We could talk about Achilles.
We could wax poetic on this for days.
And I think there's also one other thing to clarify for the people that are listening in the audience. There's 2 different flavors of Achilles tendon, right? Think of it as a rope, and there's a rupture where the rope breaks and both ends are separated and there's a huge hole in between, right? That's an acute rupture. And then there's also degenerative tears. So let's say somebody's had Achilles pain for a while. They talk to their primary care doctor, they get an MRI, and they get a report that says, oh, I have a tear in my Achilles. Sorry, excuse me. That's a different problem that we treat differently, because it's more a degenerative tear in nature than an acute discontinuity. And just so that people understand that not every, just because you have a tear doesn't mean you have a rupture, and that there is a difference between those and how we manage them.
Okay, thank you. Yeah, lots of great information about Achilles tears. Thank you so much. Let's talk about treatment options. And we've talked a little bit about operative and non-operative options for the foot. Dr. Hembree, if a previous foot surgery, and I think we talked a little bit about this too earlier, where you were talking about plantar fasciitis, and if we did surgery, usually that'll come back. So that's not why we don't always do that. If foot surgery was unsuccessful, what are the treatment options after that? What would you recommend to your patients?
Yeah, it depends on the situation. It depends on what type of surgery. I see a lot of patients that have had unsuccessful bunion surgery, for example, and usually in that scenario there are options to revise the bunionectomy, so redo the bunionectomy with surgery if it remains painful. There are other scenarios where, for example, if a patient had a major hindfoot fusion and reconstruction in the setting of, let's say, what's called diabetic Charcot arthropathy. So that's where patients with diabetes sometimes develop neuropathy. They can't feel their feet very well, and their bones will become soft and fragmented, and the joints can collapse. If we do a fusion in that scenario and the fusion doesn't take, meaning it doesn't heal, that doesn't always necessitate revision surgery, as long as the construct is minimally symptomatic and stable and well aligned. We can sometimes treat those patients in a brace at that point. And so again, just a very broad question. It certainly would depend on what the issue was, why it failed, and patient factors as well.
Okay, Dr. O'Connor, do you have anything to add to that?
Yeah, I think the not every failure is explainable. And second opinion, if somebody's had a surgery and they're unsatisfied, I don't think it's unreasonable to get a second opinion to find out whether there is something that could be done. There sometimes isn't. And I think but it's reasonable for anybody to get a second opinion. And I think, especially for us as foot and ankle subspecialists, we are a good person to get a second opinion from, because, the more complex of the foot, that's what we're more trained on than anything else.
Okay. Yeah, that makes sense. Thank you so much. Dr. O'Connor, let's talk a little bit more about what happens after surgery. Are there certain lifestyle changes that you recommend to your patients after a surgical procedure? I know, Dr. Hembree, you talked about recovery time earlier in the broadcast. What lifestyle changes do you typically see and recommend to your patients after surgery?
Well, there are certainly some that I talk about before surgery, and then there are some that we talk about after surgery. So from a pre-surgical perspective, certainly anybody with diabetes and smokers, those are risk factors for complications. So people that smoke, if we can get them not smoking, or if we can get their smoking down to a minimum, that just portends better outcomes, less risk of infection, less risk of bones don't heal as well when you smoke. Patients with diabetes, so many people have diabetes. We operate on people with diabetes, but there's diabetes that's controlled with an A1C under 7, and then there's diabetes that's uncontrolled with A1Cs in the 9s, 10s, 11s. Mm-hmm. So before surgical procedures, you want to optimize everyone. So we like to just optimize people from their health perspective. In a post-surgical perspective, ideally we get people back to doing what they want to do. Now that isn't always the case. And some people come in and they're not able to do anything. So we get them back to doing more than they were, but maybe not as much as they were doing a decade ago. I always tell people, if you like to exercise, learn to love a bike, right? It's so much less impact. Now, some people just like to run, and running is just a little bit demanding on your foot because of all the impact. So from a lifestyle perspective afterwards, it's just sort of figuring out modifications to your exercise and activity regimens that allow you to be successful with the improvements we're able to make with surgery.
Thank you very much. What about side effects? Dr. Hembree, are there any side effects after surgery that would be discussed with your patients before surgery?
Side effects. Well, I usually think of side effects in terms of medication. I guess there's always risks of surgery. Dr. O'Connor just alluded to some of those. And I tell all my patients, anytime you're considering an operation, there are risks involved. And so anytime that we lay night to skin, there are risks, things like bleeding, pain, infection, nerve injury, anesthesia risk, always chance something doesn't heal correctly and we have to redo it. All those risks are ever present, and albeit they're very low, but they do happen on occasion. And so as a patient, just have to be informed. You have to be prepared that, you've tried everything else you can do before considering an operation, and make sure that if there's any doubts, get a second opinion. As Dr. O'Connor mentioned, I encourage my patients sometimes to get second opinions if they're not sure about the way forward in terms of treatment.
Mm-hmm. Okay. Dr. O'Connor, anything to add?
Yeah, no, I completely agree with him. I think I talk to my patients a lot that, there's always a risk, and we don't always know what it is. And, but you have to be at a point where you want to accept the risk of surgery, and that what you're managing from a pain or a functional perspective, that it's worth it, that it's you're limited enough that it's worth it. And that we make people better, but we can't always make things perfect. Sometimes the tendon has disease, the bone has arthritis. We can't change that. We can just do our best to make it the best, work with what we have to make it the best that we can, but we can't always make it what it originally was. So just people understanding that, nothing is without risk, and the goal is to improve pain and improve function as best as we can.
Mm-hmm. Yep. And how long is a surgical procedure typically, Dr. Hembree? I guess it varies depending on what it is, but can you just generally give me a sense, and our viewers a sense for what does that surgical timeline look like? Even if it's pre-sur, just trying to get an understanding, how long does that process take? If I become a candidate for a surgical procedure, what am I looking at in terms of timing and next steps? How long is my surgical procedure typically going to be? And then we talked a little bit about recovery times already, but Dr. Hembree, is
Yeah.
it a 1-day thing? You're in and out of the hospital. How does that work?
Yeah, I mean, I would say the vast majority of what we do as foot and ankle surgeons is outpatient. So most surgeries are done either in a surgery center or in the hospital, but you go home the same day. Now there are scenarios on occasion where we do admit patients for observation or to go to rehab. For example, patients who have to be non-weight bearing for 3 months, may not have as much social support at home, may not be able to comply with the weight bearing restrictions on their own. Sometimes those patients have to get admitted to the hospital, and we have to get them to a rehab facility that can help them manage in the recovery process. But kind of circle back to your original question in terms of how long does the surgery take? Again, it depends on the surgery. I mean, there are simple bunion procedures that are 30 minutes to an hour, all the way up to like major hindfoot reconstructions and fusions. It can take 3, 4, 5 hours sometimes. So it just depends on the operation. I would say on average, most foot and ankle surgeries are probably 1 to 2 hours.
Okay. Thank you very much. What about advancements? I know we've talked about 3D printing earlier. Dr. O'Connor, are there any advances in recent years when it comes to foot and ankle surgery? And are there any advances that you're most excited about? I'll start with you and then I'll go to Dr. Hembree.
Yeah, so I touched a little bit about for bunion surgery. So the development of minimally invasive surgery for the foot and ankle, that is something I've actually done a few courses on this, and I'm trying to incorporate this into my practice more. It's not something I ever did as a fellow. So I've gone to 3 or 4 courses in the past year just to sort of learn techniques from people that have been doing it. I think there's a lot of potential to do that. It has much less exposure, much lower surgical, much lower infection risks, and sort of uses a less is more kind of idea that you can sort of make things work by not having open everything up. You actually preserve the body's natural ability to heal things. And we talk about it mostly with bunions, but there are ways to do that in they're working on developing that to use in other areas as well. So I think that's sort of what I'm most excited about. And that's, I think, one way it's going. We've talked a little bit about the 3D printing and the ankle replacements. Ankle replacement, they are always constantly working on technology to try and make them last longer, right? So that you put the joint in, the piece of metal, the metal piece is in, and that they last for 10, 15, 20 years the way a hip or a knee reliably lasts. And I think that's an area of development that people are always trying to improve on. And I think as we do more, we will get more technology, but it's just a little bit slower because we don't do nearly as many as we do for other joints in the body. They can only develop so quickly.
Yep. Okay, thank you. Dr. Hembree, what about you?
Yeah, I mean, I'd echo the topics we've already covered and what Dr. O'Connor just mentioned. I would say there's kind of new frontier too in terms of robotics in foot and ankle surgery, especially as pertains to ankle replacement. Robotics is very developed in other fields, be it for prostatectomies or for joint replacements in orthopedics. They're using it a lot at one of my hospitals, Union Memorial Hospital, in spine surgery. And so foot and ankle has been kind of slow to develop in the robotic realm, I would argue. And I think that it's starting to come about, especially in ankle replacement. So there are companies that are developing different types of robots to assist surgeons during ankle replacement surgery. And it's kind of exciting to see where that might go over the next 10 to 20 years and how it might expand to other types of foot surgery, not just ankle replacement.
Okay. Thank you very much for that. Yeah, that sounds very exciting. And I do have one more question from our viewers before we wrap up. This is from Sharon. Thank you, Sharon, for your question. This is a bunion question. When there's a bunion where shoes are an issue, is there more simple surgery without whole foot reconstruction? Dr. O'Connor, do you want to take that? You've been talking a lot about bunions today. We talked about, I think, when you need surgery for a bunion or not, but let's reiterate and give some advice to Sharon.
Yeah, unfortunately, Sharon, there's in order to realign the bone, you have to cut the bone, and whether you have to realign it this much or this much, so to speak, you have to sort of do what's called an osteotomy, and that's where we cut the bone. And it just takes the body a certain amount of time to heal. At 6 weeks, there's some stability. It's sort of maturely healed between 3 and 4 months. And so whether it's a small bunion or a big bunion, the cuts are the kind of the same. So there's not a quick, easy, little simple thing to do necessarily for a bunion.
Thank you very much. And bunion surgeries, can you talk a little bit about how many do we do? A vast majority of surgeries we're focusing on bunions, and what are the outcomes like? I know just personally, I've known 2 people in my life that have gone through bunion surgery with very successful outcomes. Everything's great. They're in their shoes, walking fine without pain. So maybe just something just to ease Sharon. I can imagine there's some concern about, like, cutting your, the bone. But maybe we can give Sharon a little bit more, make her feel at ease of going through that process.
Yeah, we do it and it works. There is some that we do it, and most of the time it works. There are some people who the bone doesn't heal, but again, the complication rates are sort of under 5% in terms of bone not healing, infections, all those things. But most of the time, bunion surgery actually can be relatively quite successful. Some people get a little bit, the toe slowly drifts back over time in a fair amount of people, but usually they remain painless. But it becomes, it gets a little bit, it can drift into a little bit of crookedness over time. Usually about 20 to 30% of people get that, but they don't have the same pain that they have. And for reasons we don't totally understand, but we do find that happens on a regular, relatively commonly, but people do okay with it. And usually it's pretty good for pain control when it goes the way it's supposed to.
Wonderful. Thank you.
I would add too that for Sharon, I mean, it would depend on your foot x-ray essentially. And so there are quote unquote simpler procedures. We're still cutting the bone, but there are quote unquote less involved ways to correct a bunion for bunions that are less severe. Now, I mean, there are other things that come into play, be it, overall foot alignment, arthritic conditions in the midfoot. More severe bunions in general sometimes need a little bit bigger operation, quote unquote, and the recovery for those might be a little bit longer. But that would be a conversation with your surgeon and, get evaluated, get an appropriate weight-bearing x-ray and see what type of surgery might be best for you.
Perfect. Yeah, that's an important follow-up. When is it time to, so it sounds like, so thank you again for answering Sharon's question. It would be important for her to have that conversation with her orthopedic surgeon to get a better sense for her specific situation. But when is it, Dr. O'Connor, can you answer that first? When is it time to come see a specialist for that conversation?
I mean, I think the best time to see someone is when you're having symptoms, right? If it's painful, if you say, hey, I've noticed that, like, when I go to the gym, my toe hurts and I'm not exercising the way I want to be exercising because of my toe, right? The best guidance for needing evaluation is symptoms. So if you are symptomatic, if you're having pain and discomfort, then you come in and you find out what the options are and where you sort of fall on the spectrum of things that could be done for management.
Yep. Dr. Hembree, anything to add to that?
Yeah, okay. Same thing. I mean, the primary indication is pain. I mean, there's other relative indications that we've discussed, be it difficulty with shoe wear, on occasion, balance issues. The main one is pain, though. We generally don't recommend bunion surgery for cosmetic reasons because the risks don't outweigh the benefits in those scenarios most of the time.
Yeah.
Excuse me, the benefits don't outweigh the risk is what I meant to say. Yeah.
Yep, I gotcha. Yeah. Yep. Okay, well, that's all the questions I have for you today. Thank you so much for your time. Before we wrap up, Dr. O'Connor, I'll start with you. What is 1 or 2 of the key takeaways or something you want to reiterate to make sure that our viewers get from this discussion?
I think for us, we're orthopedic surgeons that are, physicians that are trained in management of complex foot and ankle stuff. But just because we do complex foot and ankle stuff doesn't mean we don't do bunions and we don't do hammer toes, an ankle sprain. I think everything in the foot and ankle is really in our wheelhouse, and we can sort of are happy to see people as much as if people feel like they need to be seen. Plantar fasciitis, like we see that all the time. So I think some people think, oh, it's really complicated, we don't need to see an orthopedic surgeon, but that's what we do. We do everything in the foot and ankle.
Thank you. Great advice. Thank you so much, Dr. Hembree.
Yeah, I mean, I would agree completely. I mean, we take care of the whole person. So, I mean, we're orthopedically trained and have experience in orthopedic procedures in the entire body, but we focus and are specialized on the foot and ankle. And so we work seamlessly with our other subspecialists, our knee replacement surgeons, our hip surgeons, our trauma surgeons, our sports surgeons, we work with them together as a team to, treat the whole person. And a lot of these types of conditions are overlapping. And so you can have an alignment issue in your knee, for example, that might affect your foot or your ankle. And, I think it's important to have a discussion on multiple levels with different specialists in terms of how best to address those issues on occasion.
Wonderful. Thank you so much for that. That's a good segue. So if you would like some more information or to schedule an appointment, you can call 877-34-ORTHO, O-R-T-H-O, 877-34-ORTHO. We'll also add that in the comments. So if you are experiencing pain or thinking of what options you have for your foot and ankle condition, you can call that phone number. We'll get you scheduled. Thank you, Dr. Hembree, Dr. O'Connor. Really appreciate your time today. Thank you for the wonderful information. And thank you to our viewers for joining us today. Have a wonderful day, and we'll see you next time.
Thanks, Karen. Bye-bye.